Good afternoon, everyone. Thank you for attending today's webinar hosted by LifeLabs in collaboration with Ogrex. The title of our presentation today is Early RA Detection and Monitoring of Joint Damage with 1433-ADA, also known as JOINTstat. Today's speakers will be Dr. Giles Boire. Dr. Giles Boire is a professor in the Division of Rheumatology of the Faculty of Medicine at the University of Sherbrooke in Quebec, and he is also the director of the Multidisciplinary Clinic of Pediatric Rheumatology at the Centre Hospital Université de Sherbrooke. Dr. Kam Shojania, speaker number 2, is a clinical professor of medicine at the University of British Columbia, Division of Rheumatology. Since 2008, he has been the chief of the UBC division, head of the Vancouver General and St. Paul's Hospital divisions, and the UBC Rheumatology Postgraduate Program Director. The moderator, myself, is Dr. Anthony Marotta. I'm the Chief Scientific Officer of Ogrex and also a pending adjunct professor in the Division of Rheumatology at the University of British Columbia. The program overview today is that essentially, one, we will look at 1433-ADA and provide an overview of the 1433 proteins. That will be presented by myself. The clinical imperatives in RA and 1433 clinical data will be presented by Dr. Giles Boire. And then Dr. Shojania will provide some patient case studies on how he's utilizing JOINTstat in the management of his patients. Abby from LifeLabs will join in and provide details on how to order the test, the JOINTstat test. And then the last 15 minutes of the webinar will be a question and answer period. And with that, essentially, the key program objectives will be to understand how JOINTstat assists with early RA referral, monitoring joint damage risk, and targeting radiographic remission. Takeaways from today's webinar will be how to use JOINTstat to detect early RA and to monitor joint damage risk, the benefits clinically of an early RA diagnosis coupled with early access to intervention, the importance of targeting radiographic remission beyond just clinical remission, and then essentially patient case studies demonstrating how JOINTstat essentially assists with improving patient outcomes. So now it's my pleasure to talk to you a little briefly about 1433-ADA and what this protein actually is doing under normal conditions as well as in the context of RA. So 1433-ADA is essentially a protein that is made up of a family of a number of proteins. In fact, there's 7 different isoforms of the 1433 family. Now, under normal circumstances, the 1433 proteins are intracellular chaperones, and they play vital, pivotal roles in the regulation of protein synthesis. They're also important for cellular metabolism, so they play roles in the regulation of energy. They've also been shown to play critical roles in signal transduction, and obviously in the context of RA, signal transduction with the advent of a number of these small molecule kinase inhibitors is becoming more and more eminently of interest to the community. Beyond that, the 1433 proteins also play key roles in cellular trafficking. So they shuttle proteins around within the cell and regulate their function. In the context of rheumatoid arthritis, back in 2007, Kalani et al. Essentially discovered that 1433-ADA was present at significantly higher levels in RA synovial fluid as well as matched patient serum. And when they looked at various control groups in this study, they had also shown that it appeared to be differentially expressed. With that, what we elected to do was to develop a ELISA, which is now the JOINTstat test that's available clinically within Canada, And with that, we really wanted to establish what the specificity of the 14-3-eta marker was for rheumatoid arthritis. So within that study, we looked at 135 patients with established disease who had a minimum of 5 years disease duration. We also, because again we knew that the field was moving upstream to wanting to diagnose RAs earlier, we looked at an early RA cohort that had a mean disease duration of 6 months. And with that, we also looked at 385 different controls, including healthy subjects, patients with ankylosing spondylitis, gout, systemic lupus, systemic sclerosis, Sjogren's, osteoporosis, a number of inflammatory disorders, including Crohn's, colitis, psoriasis. We also looked at a cohort of psoriatic arthritis patients who essentially were comprised of non-erosive and erosive patients, as well as osteoarthritis patients. So with that, we measured 14-3-eta levels in these patients, and the data demonstrated quite significantly that 14-3-3-eta was expressed at significantly higher levels in established RA as well as early RA when we compared it to controls. And just for continuity's sake, we've also essentially shown the different controls that we investigated and their expression levels. So in general, the cutoff for positivity at 0.19 nanograms per ml falls specifically around here. And so you can see, many of the controls would be negative for 14-3-eta. And if we look at, essentially rheumatoid arthritis in relationship to healthy controls, we saw that there was corresponding sensitivity of 77% with a specificity of 92.6 or 93% when comparing to healthy controls. Now, in looking at some of these other autoimmune conditions, you do see some positivity there. And much like with other markers, and more recently even CCP, is the presence of 14-3-eta an early warning signal that some of these subjects may be at risk for subsequent development of rheumatoid arthritis. So those are some of the studies that we're currently working on, but I'm pleased to tell you, that we have seen, much like CCP, that 14-3-eta can be present up to 5 years before a patient develops disease. And in fact, higher levels are reflective or indicative of who may go on to develop disease. So part of our work will be to establish whether or not, these subjects who have other autoimmune conditions are at risk, basically, for the development of RA if, for example, they're positive for JOINTstat. And specifically, when we look at PSA, we have seen, in this small study that, in fact, 14-3-eta is elevated, and where it's tracking more so is in patients who have erosive PSA. Now, we also have studies underway to further, expand upon, this cohort and this, important thing within the management of PSA. Moving on, one of the things very early on, too, that was very important to us was if a patient is positive for the marker, what does it mean clinically? And is 14-3-3 present in the context of disease as a marker as a bystander, or is it possibly intimately involved in the pathogenesis of RA? So based on a positivity of 0.19, we subgrouped the patients in this regard, and so we had 67 patients who were negative and 167 patients who were positive. And when we looked at essentially their clinical together with some of their serology, what we found quite consistently was that patients who were positive for 14-3-3 had elevated DAF, elevated HAX, elevated SED rate, CRP, rheumatoid factor, and CCP. So based on that, and knowing what we know clinically about, some of these markers and arguably even higher DAF, we propose that patients who are positive for 14-3-3 have worse disease at presentation. And so with that, then we elected to essentially begin to investigate whether or not 14-3-3 was present as a bystander, within the disease, or if it actually contributed to the pathology. So this schematic representation really culminates, the work that we've embarked on over the last 5 to 7 years, where we've started to try to understand the role of 14-3 in the pathogenesis of RA. And as I already alluded to, under normal conditions, 14-3 eta itself is an intracellular protein. So the gray bar here really denotes the cell membrane. This is the outside of the cell, and this is the inside of the cell. So as I said, under normal conditions, 14-3 eta itself is present within the cell. In RA, what we're seeing is that 14-3 is actually externalized. And when it's externalized, we've actually shown, using clinically relevant concentrations of 14-3 eta, that when you stimulate cells with 14-3 eta, that it activates very specific signaling cascades that are very important, obviously, in the context of RA, such as the JAK-STAT pathway, obviously, with the advent of, the JAK inhibitors, as well as MAP kinase, who people have tried to target, or companies have tried to target MAP kinase to treat autoimmune conditions, for a number of years. But beyond that, these signals culminate at the level of the nucleus to really drive up transcription and translation. So you get an upregulation of inflammatory factors as well as joint damage factors. So based on this mechanism, it leads us to believe that 14-3 is actually intimately involved in perpetuating disease. And I think, obviously, you can do things, in vitro in a lab, but, to take it one step further, we really wanted to look at whether or not in an animal model system, whether targeting 14-3 eta with a biologic compound that we're currently working on can actually attenuate or reduce the overall severity of disease. So in this particular study, the main goal of study 2 was to evaluate the in vivo feasibility of targeting 14-3 with a monoclonal antibody with the view of trying to delay the onset or reduce the overall severity of disease. So this represents the study group. So we had a negative control in there. So these were non-induced animals. The positive control were 6 animals that were treated with dexamethasone. We had a placebo control, which represented saline, which was the same formulation used with, obviously, formulating the 14-3 monoclonal. So animals were essentially treated at day -2 with the respective agents, and they were treated daily up to 40 days. Disease was induced at day 0, and then the animals were boosted with collagen essentially at day 18. And you have to boost the animals at day 18 so that they start to exhibit signs and symptoms of disease by about day 22. But importantly, the compound that any of the compounds were used, essentially were administered daily. What the data showed us in this particular study was that when we looked essentially at the saline group compared to the animals that were treated with the non-optimized 14-3 monoclonal antibody therapy, there was a delay in the onset of disease, and importantly and significantly, there was also a significant reduction in the overall severity of disease when we compared it to the saline control. Now, as you can see with dexamethasone, pretty much no animals develop disease. Now, clinically, that would be great, if dexamethasone or, a steroid had that effect, but I think it's well established that, that isn't necessarily the case, with the treatment of RA. So, the fact that we can reduce the overall severity of disease is a good thing. It further highlights or underscores 14-3's role in the pathology of disease. And then just looking at things one step further, when we look at the x-rays of the saline-treated animals versus, the animals that were treated with the 14-3 monoclonal, the hazing here that's happening in the left hind paw is reminiscent, obviously, of joint deterioration. And you can see when we look at the animals that were treated with the monoclonal for 14-3 itself, that there is preservation of the joint architecture. So with this data now, we're actually moving forward with the development of a monoclonal antibody strategy, targeting 14-3 to treat rheumatoid arthritis. So those are things that Augrix is currently working on, presently. So with that, this sets the stage that 1433, is a specific RA marker, and that it's actually involved in the pathology of disease. And with that, now I'd like to pass the presentation over to speaker number 1, Dr. Giles Boire, who will talk about the RA clinical imperatives and present the JOINTstat data that has been developed to date. So, Gilles?
Thanks, Anthony. Good afternoon. It is well known that early detection, coupled with access to an effective treatment strategy during the first months following symptom onset, is associated with better clinical outcomes. This is called a window of opportunity. By identifying those patients who have a poor prognosis and treating more effectively to mitigate disease activity, it is possible now to put the disease into clinical and radiographic remission. Here, sorry, I'm trying to change the slide. Okay. Here's what we know about 1433-ETA's utility as a biomarker in RA. 1433-ETA likely arises from within the joint, since 1433-ETA levels were on average 5 times higher in synovial fluid when compared with paired serum. Others have reported, and Anthony just did, on 1433-ETA's specificity for RA, including Quest Diagnostics, Life Labs, and others. Elevated 1433-ETA may be present up to 5 years before a patient is diagnosed with RA, and higher levels in the patient preclinically increase the likelihood of developing RA. 1433-ETA levels like CRP and unlike anti-CCP, for example, can be modified. The marker changes over the course of disease and with therapy. Decreases in 1433-ETA and reversion to a negative level are associated with better clinical outcomes. So here are a few studies. The focus of this first study was to determine whether 1433-ETA preceded the development of RA and whether 1433-ETA informed who was more likely to develop disease. In the READ arthralgia cohort from Netherlands, patients with joint pain who were positive for one of the antibodies, rheumatoid factor and/or anti-CCP, were recruited and followed up for up to 5 years. Over the course of the 5 years, 43 patients developed rheumatoid arthritis and 101 did not. In this study, all the patients had one of the antibodies, but 71% of the subjects were positive for 1433-ETA at study entry. Okay, 1433-ETA levels were significantly higher, that is 3.4 times higher in patients who developed rheumatoid arthritis when compared to those who did not. In comparing the development of rheumatoid arthritis based on 1433-ETA positivity cutoffs, it was apparent that with increasing 1433-ETA cutoffs, there was a higher odds ratio of developing disease. So the higher the level of 1433-ETA, the higher the risk of developing RA. The focus of the second study was to assess whether 1433-ETA was present in first-degree relatives of patients with RA who themselves developed RA, and whether 1433-ETA levels inform who was likely to transition from a pre-synovitis state to full RA disease. In 2015, Itchen and El Gabalawi from Manitoba reported that 1433-ETA levels were higher in indigenous North Americans that had RA, and that in their first-degree relatives, the prevalence of 1433-ETA positivity increased in a time-dependent manner in and around the time the subjects transitions from a pre-synovitis state to arthritis. In conclusion, the authors said that the 14-338 may be a useful predictor of which patients are more likely to transition when there's an increased level or when the level is increasing. Next slide. The focus of the third study was to assess whether baseline levels predicted response to therapy and whether changes in 14-338 over a one-year period further informed clinical response. In this cohort of 149 Japanese patients with established RA, 14-338 levels were measured prior to initiation of therapy and following 1 year of treatments. Patients were treated with either methotrexate, adalimumab, tocilizumab, or tofacitinib. Here. Patient demographics are provided in this table. As you can see, these are established disease with already damage in this sharp Van der Heijden score of 26. And 74% of the patients were positive for 14-338 beta at baseline. Okay, sorry. 14-338 levels change over time, and the change was different between patients. In some, the levels started very high, for example here, and decreased to low or even negative levels. In others, the levels started low or negative and became quite high. In some cases, the levels only slightly decreased, like here, or stayed relatively the same. So the question was, with 14-338 being mechanistically involved in the pathogenesis of RA, it might be interesting to determine if decreases in 14-338 were associated with better clinical outcomes. Clearly, the levels of 14-338 at year 1 were significantly lower than the corresponding baseline levels across all therapies. A paired t-test was used to determine if the values were significantly different at the 2 time points. So as you see, it's significant for every difference, every therapy. ANOVA analysis revealed that patients who became negative for 14-338 at year 1, those are the blue ones here, had better 1-year DAS28 ESR outcomes when compared to those patients that remained positive, the red ones here. 70% of the patients who became negative were in DAS28 ESR remission at 1 year. Importantly, there was no significant difference in baseline DAS28 levels between those patients that remained positive or those that became negative, indicating that both groups started at the same level. In this study from Sherbrooke, 14-338 levels were serially measured over a 5-year period in a cohort of 331 early undifferentiated patients, but who fulfill either the 2010 or the 1987 criteria for RA. The patient demographics are indicated here. The focus of this study was to assess whether serial changes in 14-338 inform both clinical and/or radiographic outcomes. Okay. When used in combination with anti-CCP, here, or rheumatoid factor, or both, the presence of elevated 14-338 serologically identified up to 37 patients more of the polyarthritis patients as RA. So it might be useful to help serologically determine rheumatoid arthritis. Next. Titers of 14-338A correlated modestly with rheumatoid factor and anti-CCP levels. But of note, 14-338A titers did not correlate with acute phase reactants like CRP or ESR. When we combine CRP and 14-338A, this identified patients who were at highest risk for significant radiographic damage progression over 30 months. So those that were both positive were at much higher risk of progression. This is the change in the Sharp van der Heide score. In particular, 60% here of the patients with both an elevated CRP, that is higher than 8 milligram per liter, and a positive 14-338A, at least 0.19 nanogram per ml at baseline, were more likely to experience radiographic changes of at least 5 units using the Sharp score over 30 months compared to those that had only one elevated or that were negative for both. As patients with both an elevated CRP and 14-338A appear to have a poorer prognosis, one may hypothesize that these patients may benefit from being treated more aggressively. In the same patients from Sherbrooke, we determined that a higher percentage of patients experienced significant change in their erosion scores, that is a progression of at least 5 units, based on a 14-338A level of at least 0.50 nanogram per ml over a 5-year period when compared to those individuals with a level below 0.50 at baseline. So the level at baseline was made possible to predict which patient progress rapidly as erosion-wise. Next. In the same patients from Sherbrooke, we determined that the higher percentage of patients experienced significant changes in their erosion scores of at least 5 units, based on a 14-338A level of at least of at least 0.50. Sorry, I think of at least 0.50 nanogram per ml over a 5-year period when compared to those individuals with a level below 0.50 nanogram per ml. In this analysis, we look at the patients who were either in remission or not in SDI remission at 18 months, and then we further divided them according to the presence of elevated 14-338A positivity at the 0.50 nanogram per ml. Not surprisingly, in red up here, patients with disease that was still active and which also had a positive 14-338A test at 18 months had the highest radiographic progression at 30 months and then continue to progress. Progression in these patients was similar to those patients that were clinically in remission, in blue here, solid line, but had also a positive 14-338A test at 18 months. So the progression is very parallel. Thus, despite being in remission, a positive 14-338A identified patients who were at risk for more rapid radiographic progression. On the contrary, the patients who had both a low level of 14-338A, below 0.50, and were in SDI remission at 18 months, did not progress at all between 30 and 60 months, indicative of a radiographic remission. So, in summary, the next slide, I cannot advance it, sorry. So in summary, there is still a high unmet need for early RA diagnosis, joint damage prognosis, and monitoring. JOINTstat, or 1433-eta, is a mechanistic biomarker that plays a role in disease. 1433-eta positive patients have more severe disease at presentation and a worse prognosis clinically and radiographically. 1433-eta combines with acute phase reactants to identify high-risk patients, and clearance of 1433-eta or persistent negativity tends to be associated with better clinical outcomes. Persistent positivity is associated with a lower likelihood of achieving clinical remission and a higher likelihood of worse prognostic radiographic outcomes even in patients in clinical remissions and even in SDI clinical remission, which is a severe definition for remission. Subjects with arthralgia who are 1433-eta positive also have a higher likelihood of developing RA, so it may be used in preclinical patients. Thank you.
Thank you, Dr. Boire. At this point, it's my pleasure now to introduce Dr. Kam Shojania, who will basically highlight how 1433-eta, or JOINTstat, is assisting with his day-to-day patient management. Kam?
Thank you very much. It's a pleasure to speak with everyone. And it was very interesting to hear you and Gilles speak. This is certainly an area of change and increased understanding. And I think that's why I think it's changing in my practice how I use this test. So let's go to slide 30. My first example, my patient with seronegative polyarthritis. As other rheumatologists also get, I get some patients who have definite inflammatory polyarthritis with swollen joints, MTPs, wrists. It's like this patient, 14 swollen joints, MCPs, PIPs, one wrist, and tender MTPs in the feet. She is RF negative and CCP negative, but the CRP is 14. Basically, if this was before JOINTstat, I would definitely say this person had seronegative polyarthritis. I might even say rheumatoid. I would be checking her for psoriasis. I would be getting her family history for psoriasis. But now, if I get a positive JOINTstat like I did in this case, rheumatoid arthritis was confirmed. I can comfortably stop there. This is seropositive rheumatoid arthritis with, I think, a more significant worse prognosis, and I'm more likely to treat aggressively. If it was seronegative, RF negative, CCB negative, and I didn't have any other results, I may use methotrexate. JOINTstat positive, I'm going to go with triple therapy. Now, my question is, do we repeat the JOINTstat when she's in remission? And I'll talk more about that later. But yeah, this is a typical case, and I think that lots of my colleagues would agree that in the seronegative rheumatoid arthritis, a positive JOINTstat is very helpful in clinching the diagnosis of rheumatoid arthritis. So we go down to slide 31. Example 2, this patient has polyarthralgias. So this is a 29-year-old woman that I saw with several months of migratory polyarthralgias, but you know, it was suspicious. Fingers, wrists, MTPs, morning stiffness for an hour. Got an ultrasound of the fingers with Dr. Collins here, who does MSK ultrasound, and the results were no obvious synovitis. She's RF negative, CCP negative. Her CRP is borderline elevated at 6, but her BMI was also up too, so I wasn't convinced. You know, it just worries me when I'm going by only subjective symptoms before starting treatment. So JOINTstat positive in this case made me more comfortable about just hitting her with methotrexate. JOINTstat negative, if it was negative, I would observe, I would possibly consider hydroxychloroquine, but I would be more reassured that she's likely not going to be erosive long term unless we see obvious synovitis or Doppler change on ultrasound. So those are two cases. Let's go to slide 32. This is where I'm now moving to. So let's take, similar to number one, established RA, but in this case the patient is RF positive and CCP positive. Now, why would you get a JOINTstat here? It's irrelevant in the diagnosis because we know this is rheumatoid arthritis. I'm starting to do JOINTstat initially in people who can pay for it. And I'll tell you why. And this reminds me, and some of you will remember the old days when we just had rheumatoid factor and CCP came in, and we were considering who to order the anti-CCP on, and lots of us were saying, well, if it's RF positive rheumatoid arthritis, you don't even need a CCP. What's the point of getting it? But now I think all of us are getting their CCP and rheumatoid factor together at the same time. Anyway, going to this patient, I did get the JOINTstat. It was positive, so I'm calling her triple positive. She eventually became well controlled on methotrexate and etanercept after triple therapy failed. She has no erosions, and now she has no synovitis for a year. CRP is less than 1 for 2 years. We've tapered the methotrexate down to weekly. Etanercept is 50 milligrams weekly. She, as many of our patients do, wants to reduce medications further or even stop one of her medications at this point. So now I get her JOINTstat and has gone from positive to negative. At this point, based on the data we have so far, I'm more comfortable in suggesting tapering and discontinuation either of methotrexate or etanercept, and I guess based on patient preferences, though I think I would probably like to reduce her etanercept to every 2 weeks, maybe go to every 3 weeks, then stop it and leave her just on the methotrexate. So now I've got 3 cases where I've ordered it, and if you move to the next slide, where are the opportunities to assist with RA patient management? So, you know, the first one, for example, in combination with RF and CCP in individuals suspected of having rheumatoid arthritis, or are they double or triple positive? At the time of diagnosis, or similar to one, should we do it in follow-up? It seems to me the JOINTstat is helpful for diagnostic purposes, but also it's kind of like a CRP in the way that it can reduce or normalize with remission or improvement in care. Should we do it prior to therapy switch? If someone was positive, goes to negative, then becomes positive again with symptoms, is it time to dose increase or switch therapy? Should we be doing it annually? I'm not saying we should. I'm just throwing these ideas out there. And then, similar to my case, in patients in stable remission where tapering or discontinuation of the DMARD is contemplated. Next slide. The last slide for me, just as a reminder, a JOINTstat over 0.19 nanograms per mil is positive. If it's over 0.5 nanograms per mil, it's higher risk for radiographic damage progression. And if you're monitoring, serial decreases or a negative JOINTstat level may assist you with looking at outcomes. And I'll stop there.
Thank you, Kam. I'd like to take this time to thank both of our speakers who did a tremendous job. Gilles for presenting the current data on 14-338, and Kam, certainly it's great to see, you know, things more at a patient level, to see how it's assisting, how JOINTstat's assisting you with day-to-day patient management. At this time, I'll pass the presentation over to Abby from Life Labs, who will come in and provide you with an overview of how the JOINTstat test can be currently ordered.
Thank you, Anthony. Thank you, Dr. Boire. Thank you, Dr. Shojania. Life Labs is proud to be the exclusive national partner of Augurex to provide this high utility test in the Canadian marketplace. How can physicians order this test? In the province of British Columbia, physicians can write JOINTstat on the MSP requisition, and the patient can take the requisition and walk to the nearest patient service centers of Life Labs to get the test conducted. The physicians in Ontario can write JOINTstat on a separate requisition. There is a separate requisition required for this, so please ask your Life Labs representative to provide you with that separate requisition if you don't have one. Once you write the separate requisition in Ontario, the patient should take the requisition and go to the nearest Life Labs PHC and get the specimen drawn. The reports will be available through 3 options as you choose: through Acceleris, EMR platforms, through My Results for patients, and through fax. Within 8 to 10 business days. The price of the test in Ontario and British Columbia is $75 and paid by the patient out of pocket. And last point, we here at Life Labs are doing every possible effort to develop commercial partnerships with entities such as insurance companies and pharmaceutical companies and patient support program companies to ensure that at a point of time, patients will not have to pay for this test.
Thank you, Abby. That is very much appreciated. At this time, we'll entertain questions and answers, questions from the attendees. I believe that you can do that. You should have a box on the right-hand side of your screen when you've logged in, where essentially you can type your questions. And Abby, I'm not sure if I'm going to be able to see those questions, so if you can, it would be wonderful for you to let us know about those questions.
Sure. I have unmuted the physician attendees.
Fabulous. Oh, okay, that's even better. So if there's any questions from the attendees, please feel free. We're happy to dialogue at this particular point.
Hello? Hello?
I had a quick question. Hi, this is Nada Amiri. I just wanted to confirm something. I was wondering what proportion of patients who we end up diagnosing as rheumatoid arthritis who are both rheumatoid factor and anti-CCP negative are JOINTstat positive. I think the slide that you presented said 37%, but I just wanted to see if I interpreted the data correctly.
Gilles, would you like to address that, or? I certainly can. So Abby, could I please have control of the, I don't know if I have control of the slide deck, but could you please do me a favor? Okay, I'm just wondering if I can quickly jump to the corresponding slide. Okay, oh, I passed it. There we go. Oh, stop. So basically, in this cohort of 331 subjects, if you look at 1433, you know, on its own, 46.4% of the patients, or 153 patients, were positive for 1433, 140 positive for CCP, so 40.3. When we look at rheumatoid factor, 44.2 were positive. If you layer on 1433 to each of the respective markers, so when we combine 1433 with CCP, up to 36.8% of the patients who were CCP negative were positive for 1433, with rheumatoid factor 24%, and in combination with rheumatoid factor and CCP, up to 15% of the patients were positive. So out of 100, patients, in that case, we would expect that 15 would be positive for JOINTstat. if you're using 14-3 in combination with rheumatoid factor or CCP. Other questions?
Hello.
Hello?
Yes, Dr. Blocka here.
Yeah.
Hi, I'm not sure if I'm on air. Am I?
Yeah.
A very nice presentation. Thank you very much. Just a small question. In the original study cohort that you looked at across various disease spectrums, obviously you looked at JOINTstat and osteoarthritis. Could you clarify what type of osteoarthritis that was, and whether you looked at the subset of OA that has erosive changes, and whether there was a difference at all in that particular subset with respect to the JOINTstat positivity?
Yeah, great question. So that was essentially a cohort of patients that were provided from Vivian Bykirk. They had different joints involved, so, and they may have had different erosion scores as well. The study wasn't designed to, at that case, to look at essentially whether or not in OA we could differentiate between erosive and non-erosive, or even arguably inflammatory versus non-inflammatory. That is something that we're currently looking at doing.
Okay. Thank you.
My pleasure. Other questions?
Ken here again. I had a question for Dr. Shojania. The interesting sort of case situations you presented where the patient may be, an RA patient may be in clinical remission, however the JOINTstat remains elevated. I'm just wondering from a practical point of view how you would approach that patient therapeutically. What would you do under those circumstances?
I would probably not taper I would not readily taper the DMARDs at that point. I would hold steady. I would tell the patient that there's an increased risk that you're going to flare. I'm not comfortable tapering much further or stopping. And Anthony, I think you have some data in that regard. If they're JOINTstat positive, and as Giles might, right, that they're more likely to flare coming off DMARD.
I guess my question really more to the point would be whether you would in fact be inclined to escalate therapy because of the presumed risk of ongoing radiographic damage. Is there any grounds to suggest that strategy?
I don't. I think that if clinically they're in remission but the JOINTstat is positive, I would hold steady. I'm not yet increasing therapy to treat the JOINTstat.
Yeah, it's a difficult situation we do encounter from time to time. Thank you.
Yes, absolutely. I know, Giles and Anthony, comments on that one?
Yep.
Well, Giles, I don't have information. It's a situation where you have to be careful, but it's an increased risk. It's not necessarily something that will happen, so you have to be careful with those patients. It's a warning sign. It's not. Personally, I don't know what you should do. There's no real data to tell whether you treat elevated 14-3 by itself, whether it changes the outcomes. We don't know that.
Yeah, and I think that's an important prospective study that may need to be done, so to speak, to treat to the 14-3, but certainly right now obviously the bulk of our studies have been retrospective studies.
Correct. Yeah.
So that might be something that again, if there's investigators on the call who are interested in potentially doing something like that within their clinic, it could be something that essentially we work on in collaboration together.
Thank you.
Other questions? Well, I guess if there's no other questions, I'm happy to say thank you very much to everyone who joined us for today's webinar. And at the same time, again, I'd like to thank Dr. Shojania and Dr. Boire for joining us on today's webinar. And with that, I'll say thank you and wish you a wonderful afternoon.
Thank you very much.
Thank you.
Thank you.